Today we are going to discuss Unit 10 Paraphilic Disorders. And then in the last we will discuss Unit 12 and 13. So we are going to discuss about the sexuality, what is normal sexuality, sexual response cycle, gender differences in sexuality, paraphilic disorders, etiology of paraphilias, treatment of paraphilias, gender dysphoria, transsexualism, and sexual dysfunctions. So, sexuality is considered to be one of the most private aspects of life, which may contribute to love, happiness, and pleasure. However, sex is considered as a taboo in various societies and cultures, and people abstain talking about it openly. Sex is often associated with curiosity. People have often used various modes to abate this curiosity, like prehistoric times cave drawings, Indian text Kama Sutra, Leonardo, Leonardo da Vinci anatomical illustrations of intercourse, and various pornographic sites on internet. Some important terms to remember: sex, it is quality of being male or female; sexual intercourse, insertion of penis when erect in vagina. Other forms include anal sex, penetration of the anus by the penis, oral sex, and fingering. Sexuality encompasses sex, gender, identities, role, sexual orientation, pleasure, intimacy, and reproduction. Sexual health, the integration of somatic, emotional, intellectual, and social aspects of sexual being in ways that are positively enriching and enhance personality, communication, and love. Sexual rights, rights free of coercion, discrimination, and violence. Sexual norm, it could be a personal or social norm, culture having a norm regarding sexuality and defining it on the basis of age, consanguinity, and race. What is normal sexuality? Definition of normal or desirable human sexual behavior may vary with time and place. For instance, von Krafft-Ebing, 1902, claimed that early masturbation would damage the sexual organ and would lead to the exhaustion of a finite reservoir of sexual energy. Victorian view was that too much sexual activities and sexual appetite was dangerous and thus had to be restrained using various ways. Current views contemplates that if the sexual fulfillment becomes difficult or socially acceptable, then that would be considered as abnormal. In Ayurveda, also, there are so many things written about sex and masturbation. So, three kinds of sexual behavior meet current definition: gender identity disorder, psychological dissatisfaction with the biological sex of himself or herself, sexual dysfunctions, difficulties while having intercourse, paraphilia, sexual deviations. One way to understand normality has been to understand the norm or what is prevalent in the society, although it may not be necessarily the most correct or accurate way to go about it. Sexual response cycle. Desire phase. A sexual urges occurs as a response to the sexual cues or fantasies. Arousal phase. This stage is like the preparation for main event and involves foreplay as well. Plateau phase. Changes noticed in the arousal phase are intensified. Genitalia may become highly sensitive. Orgasmic phase. This is the climax of the sexual response cycle that involves involuntary muscle contraction. There is a rapid intake of oxygen followed by sudden forceful release of sexual tension. Last one is resolution phase. This stage is marked by decrease in arousal followed by orgasm. It is marked by a general sense of well-being, enhanced intimacy, and fatigue. Gender differences in sexuality. It has been reported in some studies that males engage more in sexual thoughts, sex masturbation, and sexual behavior than females. Males are also found to be desiring more sexual partners in comparison to females. Masturbation is also common among males and has not found to be in correlation with later sexual functioning, the frequency of intercourse, or any sexual adjustment. Like there are so many myths associated with the masturbation. Casual sex is often initiated by alcohol, and women seem less likely to view it as a positive experience than men. Let us see the paraphilic disorder. Paraphilias are recurrent, intense, sexually arousing fantasies, urges, and behavior that involve a non-human object, for example, shoe, hair, etc. B. Suffering or humiliation of oneself or partner. C. Children or other non-consenting people. Paraphilias are unusual sexual interests, not causing harm to the individual or others. It is only if they cause harm they are considered as paraphilic disorders. It is to be diagnosed if the condition lasts at least for 6 months. Problems in diagnosis. Individual does not experience distress. There are some categories of paraphilias which are also compatible with psychological health and happiness and may neither have signs of distress and may also involve two consenting adults. Such behaviors are more prevalent in urban areas and becoming more prevalent could be due to westernization in our country. Paraphilias have a compulsive quality to themselves, and as per research, some individuals require orgasmic release as often as 5 to 10 times per day. Let us see the types of paraphilia. Fetishistic disorder. The fetishistic disorder is marked by recurrent, intense, sexually arousing fantasies, urges, and behaviors that involve the use of some inanimate object or part of the body to obtain sexual gratification. There is a persistent use of or dependence on non-living objects or specific focus on a body part, non-genital, for sexual arousal. Majority of the reported cases of fetishism are of males. Female fetishists are extremely rare. Some continue their fetish by themselves in secrecy by kissing, smelling, shaking, fondling, or just gazing at the object of interest while masturbating. The attraction for a fetishist may seem involuntary and irresistible or compulsive in nature. Person cannot control. The disorder may begin in adolescence, although it may acquire its special significance even earlier than this, that is, during childhood. This could be explained in terms of classical conditioning and social learning theories. Voyeuristic disorder. It involves a recurrent and intense desire to obtain sexual arousal and gratification by watching others in a state of undress engaging in sexual activity. Such individuals usually masturbate during their peeping activity and achieve orgasm either while watching the activity or while remembering the incidents. They are commonly called as peeping toms, mostly male. It is the element of risk that is important for the voyeur and the anticipation of the reaction of woman once she would get to know about him watching her. Another type is exhibitionist disorder. It is a recurrent and intense urge, fantasy, or behavior to obtain sexual gratification by exposing one's genitals to others without their consent and in inappropriate circumstances. There is rarely an attempt to have an actual contact with the stranger. In some cases, the exposure of genitals is also accompanied by suggestive, vulgar gestures or even masturbation. It has been understood that the element of shock is highly arousing to these individuals. Exhibitionism is commonly seen to co-occur with voyeurism, sadomasochistic interest, and cross-dressing. It is mainly the intrusive aspect of the whole act, along with the violation of norms related to modesty, respect, and privacy of an individual about private parts, due to which exhibitionism has been considered as a criminal offense. The urge of the exhibitionist to expose is overpowering or uncontrollable and is perhaps triggered by anxiety, restlessness, and sexual arousal. After the act, they may regret and repent it, but in the tension of the moment, they may not even care for the legal obstructions. Sexual sadism and masochism disorders. Both sadism and masochism are about whether inflicting pain, sadism, or others, or suffering pain themselves, masochism. Sadistic disorders, first we'll see. A sadist may slash a woman's wrist, spank her, tie her up using a harness, and stick her up with a needle to experience orgasm. The act may vary in intensity from one sadist to another, from fantasy to severe disfigurement, damage, and even murder in some cases. In certain cases, sadists are found to mentally replay their torture and harm inflicted on others later while masturbating to attain orgasm. Masochism disorder. The person must have experienced recurrent and intense sexually arousing fantasies or behaviors that would involve acts of being beaten, bound, or humiliated. It may also include autoerotic asphyxia, involve self-strangulation. Another type of paraphilic disorder is pedophilic disorder. This is also criminal act. Pedophilia, wherein ped is in Greece for child and philia means attraction. It is diagnosed when adults are said to derive sexual pleasure through sexual contacts with prepubertal children or adolescents. The offenders has to be at least 18 years of old and at least 5 years older than the child. The person with with this disorder is sometimes content with just stroking the child's hair, but may also be found to be fondling with the child's genitalia or encouraging the child to manipulate his or her genitalia. If not found by adults or protested by the child, such acts may continue for months or even years. Thus, it is considered to be the most tragic sexual deviance. Almost all the individuals with pedophilia are males, and about two-thirds of their victims are young girls between the ages of 8 and 11. These child molesters are usually found to engage in various cognitive distortions which are self-justifying in nature, such as the child will benefit from the sexual contact and that the child often initiates such contacts. The Government of India passed the Protection of Children from Sexual Offences Act, called POCSO, in 2012 to effectively address the menace of CSA, child sexual abuse. POCSO Act was modified in 2019 to include death penalty for aggravated sexual assault, strict punishment to those engaging in crimes against children, levying fines and imprisonment to curb child pornography. To facilitate direct reporting of child sexual abuse and the timely disposal of cases, the Ministry of Women and Child Development launched POCSO e-box. Another type of deviation is incest. It refers to sexual intimacy and relations between close relatives between whom marriage is forbidden as per the societal norms. These are culturally prohibited sexual relations between brother and sister or a parent and child. Incest is considered as a taboo in almost all the societies, with Egyptian pharaohs being an exception, who would marry their sisters to save royal blood from contamination. Otherwise, we won't see any culture which permits such marriages. Families with cases of incest are usually extremely male dominated and patriarchal, and the parents are also usually more neglectful and emotionally distant. Let us see the what are the causes of paraphilic disorders. Let us see the how psychodynamic model explain these behaviors or these disorders. So psychodynamic approach was, we all know, given by Freud. Psychological health is maintained when there is a balance among id, ego, and superego. You all knowing that id, ego, and superego. If these are in conflict, it will result in psychopathology. Conflict is reduced by using defense mechanism. So this behavior can be interpreted as defense mechanism. Another model is called behavioral model. So this model is based on behavioristic school of psychology. Psychopathology is the result of learned reactions to environmental experiences, and faulty learning is the result of either classical conditioning or operant conditioning. And cognitive model basically first introduced by Albert Ellis and Aaron T. Beck. This model proposes psychopathology to be the result of individual acquiring irrational beliefs, developing dysfunctional ways of thinking, and processing information in biased way. Whereas humanistic models undertakes the concept of insight into behavioral and emotional problems. People acquire psychological conflicts, however, they have the ability to acquire self-awareness, values, sense of meaning of life, and pursue freedom of choice. The sociocultural model basically talks about the different factors. So, sociocultural factors play an important role in the development and course of mental disorders or sexual deviation. Individuals' culture and group value system play an important role. However, they may also act as protective factors against psychopathologies. So, cognitive distortions in paraphilic disorders. Some examples I will be giving. Misattributing blame. Like pedophilic disorders, the patient said that she started it by being cuddled. In the exhibitionist disorder, patient may say the way she was dressed, she was actually asking for it. Another type of distortion is denying sexual intent. So, pedophilic may say that I was just teaching her about sex. It's good, it came from her father. Whereas exhibitionist patient may say, I was just looking for a place to be, justifying the cause. Pedophilic may say, if I wasn't molested as a child, I would never have done this. Whereas exhibitionist may say, if I only knew how to get a date, I wouldn't have to expose myself. Another is deflecting censure. This happened years ago. Let's just forget about it. Generally, pedophilia gives such logic. Whereas exhibitionists say, it's not that I have raped anyone. I have not raped. So let us see what are the treatments available for this disorders, paraphilia. Behavior therapy. This this is mainly directed at the altering the association from arousing to neutral. So, like the person get aroused from various objects, the person may sexually aroused by seeing a child, So the main job is the association should be rare. So covert sensitization is used for it. The patients are asked to associate sexually arousing images in imagination with reasons as to why they are harmful. Cognitive therapy, we all know. Cognitive procedures are like they are also used to counter distorted views and modify them. Therapists also use social skills training and sexual impulse training to modify these thinking patterns. Empathy based training modules are also designed to help the sexual offenders. Let us see the another category of sexual deviation, that is gender dysphoria. Gender identity. The essence of masculinity and femininity is a deep-seated personal sense and has been termed as gender identity. Gender roles are about the masculinity and femininity of overt behavior. Some people feel as if they are trapped in the body of wrong sex. That is, their physical gender is not consistent with their sense of identity. The male may feel that he is not very comfortable in his male genitals. The gender identity disorder is termed as gender dysphoria. It is the discomfort one has with one's sex based physical characteristics or with one's socially assigned gender. It is worth noting that the degree of dysphoria may vary or fluctuate over a period of time within the same individual. Due to the discrepancy between their biological sex and psychological gender, they are called as with mental disorders. They are laughed upon and marginalized by their society or peer groups. Children with gender dysphoria are not often included in the play groups and face exclusion. They are more likely to develop homosexuality than transsexualism. Let us see the difference in male and female. Boys with gender dysphoria usually show a marked preoccupation with the activities which are typically and traditionally defined as feminine. They prefer to dress like girls and enjoy activities and games like playing with dolls. Whereas girls with gender dysphoria usually recoil or become hesitant if their parents attempt to dress them up in traditional feminine clothes. They prefer short hair and fantasize typically powerful heroes like Superman, etc. They show lesser interest in playing with dolls and rather are interested in other sports. They are called tomboys. Let us see the another sexual deviation, that is transsexualism. Adults with gender dysphoria may have a desire to change their sex permanently and transit to the gender with which they identify. This has tight associations with perceived gender roles within a particular society. It is a basically rare disorder. About 1 in 30,000 males and 1 in 1 lakh females, this desire is seen. Some recent studies have suggested that approximately 1 in 12,000 men in Western countries opt for it. Many transsexuals were reported to have gender dysphoria as children. Homosexual transsexual, they are very much like gay men with same-sex orientation. Autogynephilic transsexuals, they are attracted to thoughts, images, or fantasies of themselves as women. Reasons for transsexualism. Some prenatal hormonal influences. Children with gender identity disorder may later become transsexuals. Some families are more in support of their boys' defeminization as compared to others. So let us see the treatment available for transsexual or gender dysphoria. Usually, psychotherapy is not very effective with adolescents or adults with gender dysphoria. However, surgical sex reassignment has been found to be effective. Biological men are given estrogen for breast development, skin softening, etc. And biological women are given testosterone to increase facial and bodily hair, deepen the voice, and cease menstruation. Only a small section of female to male transsexuals seek an artificial penis as the surgery is quite expensive and also not very well developed. Artificial penis is not capable of erection and thus they must always rely on artificial ways to have intercourse. Sexual dysfunctions. So till now we have discussed about sexual deviations. There are certain sexual dysfunctions means inability to perform satisfying sex. Impairment in the desire or ability to achieve sexual pleasure and gratification is called sexual dysfunction. It may mainly be divided in three categories involving sexual desire and arousal, orgasmic disorders, and sexual pain disorders. Sexual dysfunctions may occur in both homosexual and heterosexual couples. It may be due to psychological or interpersonal reasons or may have physical factors involved. May be due to side effects of medication. Male hypoactive sexual desire disorders. A person diagnosed with hypoactive sexual desire disorders has little or no interest in any sexual activity and has been distressed due to low level of sexual thoughts and desires for at least 6 months. There are men who may have sex but just to keep their marriage safe and in reality do not think about sex at all. It could be due to some problems emanating from partners due to some cultural beliefs or even personal vulnerabilities or a medical condition. In most of the cases, it is situational and transient. Another dysfunction is erectile dysfunction, which is also very commonly seen in men. Individuals with arousal disorders may have sexual urges and a strong desire to have sex, but the problem lies is in physical arousal. A male with an inability to achieve or maintain erection sufficient enough for sexual intercourse is diagnosed with the erectile disorders or dysfunction. It is diagnosed only when the difficulty has a psychogenic origin for a combination of psychogenic and medical factors are involved. Anxiety about sexual performance can lead to erectile dysfunction. Cognitive distortions associated with anxiety in dysfunctional men may interfere with sexual arousal. For majority of men who take antidepressants medicines, SSRIs, erectile dysfunctions could be a side effect. But when the medicine is stopped, the side effect will also be vanished. Increase in age can also lead to erectile difficulties. Most of the cases of erectile dysfunction in older men can be due to vascular diseases due to which the ability of the penis to hold blood decreases to maintain an erection. Smoking, alcohol abuse, and obesity are associated lifestyle factors, and lifestyle changes can improve erectile function. Or it may get worsen also if the person has not worked on obesity. Another problem is premature ejaculation. Ejaculation may occur before, on, or very shortly after penetration. The average duration of time to ejaculate with this disorder is almost 15 seconds. Very importantly, the major consequence of this disorder is failure to the partner to achieve sexual satisfaction and also embarrassment for the early ejaculation man. Due to early ejaculation, both the sexual and interpersonal relationship of the individual with their partner gets impacted negatively. The ejaculatory impulse is under voluntary control at least to some extent. They can forestall ejaculation from penetration to almost 10 minutes. Men with early ejaculation are unable to do so effectively. Some factors like higher anxiety levels, high penile sensitivity, or high level of arousal to sexual stimuli is one of the reason for premature ejaculation disorder. Another is delayed ejaculation disorder. It refers to the inability to ejaculate during intercourse in men. Men with total inability to ejaculate are rare, and about 85% of men who have delayed ejaculation disorder can achieve orgasm by getting stimulation in other ways, mainly during solitary masturbation. In some other cases, men can ejaculate in front of partner but only through manual or oral stimulation. Delayed ejaculation can also be due to physical issues such as multiple sclerosis or use of some antidepressant. Let us see the female sexual dysfunctions. So, female sexual interest or arousal disorder. Women who have low sexual desire also have lower level of arousal during sexual activities. Psychological factors have an important role to play in reduced sex drive. Diagnosis is complex due to variable frequency of sexual contact in normal individuals and therefore depends upon the judgmental aspect in mental health professionals. Testosterone may also have a role to play in diminishing sexual desire, but replacement therapy is beneficial both in men and women, only in the cases of people with very low level of this hormone. Some factors like daily hassles, worries, poor relationship, and lesser satisfaction, conflicts, and disagreement, weak and reducing emotional bonding are main reasons of female sexual arousal disorders. Another disorder seen in female is genitopelvic pain or penetration disorders. There are two types of disorders, vaginismus and dyspareunia. A vaginismus was understood as an involuntary spasm of the muscles near the vaginal entrance, thus preventing penetration and sexual intercourse. Women diagnosed with vaginismus basically complain of pain during penetration and anxiety before and during sexual intercourse. Dysphagia. The chief symptom of this disorder, basically genital pain associated with sexual intercourse encounters, is common in women with vaginismus as well. Genitopelvic pain disorders have more of a biological basis than psychological. It, it could occur due to infections or inflammation of the vagina, vaginal atrophy that may occur with age, scars or bruises from vaginal tearing, or lack of sexual arousal. Some researchers have argued against categorizing sexual pain disorders as sexual disorders, as the pain caused here is qualitatively similar to the pain in other areas of the body, and even the cause of pain is similar to other pain disorders. So they basically argue that this disorder should be put under somatoform disorders or pain disorders rather than sexual disorders. Female orgasmic disorders. Those women who have no issues pertaining to sexual arousal or otherwise enjoying sexual activities but show recurrent delay or absence of orgasm after the excitement phase. Achieving orgasm through clitoral stimulation during sexual intercourse is such a common occurrence and thus is not regarded as a dysfunction. However, there is a small percentage of women who can achieve orgasm only through the direct mechanical stimulation of clitoris, oral stimulation, or through electric vibrators. And there are some who are unable to achieve orgasm under any sort of stimulation called as lifelong orgasmic dysfunction. Some common contributing factors like feeling fearful about the sexual relationship, feeling of inadequacy, anxiety and tension, sexual guilt, fake orgasm are the causative factors for these disorders. Okay, so till now we have discussed about the sexual dysfunction and sexual uh, deviations. Now we are going to discuss about the Unit 12 and Unit 13, childhood and neurodevelopmental disorders. Childhood depression is very common, we all know. Many clinicians before 1970 share this belief that children are incapable of exhibiting and experiencing depression. It may now widely accepted that children may display depressive features. In some cases, the children may even attempt self-harm or suicide. Majority of children with depression also have a comorbid disorder, most common being anxiety, conduct disorders, and ADHD. We will discuss about this disorder in detail. Childhood depression. Let us see the what are the causes. So, a strong association between parental depression and children's behavior and mood problems. Prenatal exposure to alcohol during pregnancy, an experience of trauma in childhood, the effect of mother-child interaction in transmission of depressed affect. Interpersonal factors, especially the poor peer relationship, may contribute to the negative effect. And neglect, trauma, abuse is actually very much associated with childhood depression. Let us see the how we can treat childhood depression. Antidepressants used with adults have proven to have less effect on children. So it's not like that the same medication which are given to adult can be given in less quantity to children. No. So psychological therapy with children aims to provide a supportive emotional environment for the children to enable adaptive emotional expressions. Play therapy is commonly used in which the child can express his or her feelings and concerns through the medium of play. Another disorder seen in children and adolescents is elimination disorders. It is related to defecating and urinating difficulties in children. Children may eliminate stool and urine at inappropriate time and places. They may swallow bed most of the time. There are two types of elimination disorders, enuresis and encopresis. Let us see what is enuresis. Enuresis is called bedwetting, urinating in the bed or during the sleep. Is not considered to be a problem before the age of 5 years. So, till 5 years, if the child is bedwetting, it's not considered as enuresis. Children who experience bedwetting beyond 5 years of age, which is not organic, caused by caused are classified with the problems of functional aneurysm. So, if caused are physical or medical, so then it is not called aneurysm. Another elimination disorder is encopresis, defecating in during the night or in the clothes. An inability to learn toileting for bowel movement beyond the age of 4 years. Less common than aneurysm. The incidence rate of the for encopresis is about 1% of 5 years old. A common time is usually afternoon, after school, or during school hours. The encopresis is seen. So let us see the what are the causes of elimination disorders. So age, parental history of enuresis, and sibling history of enuresis or encopresis. So there might be some biological or genetic factors related to this disorder. Psychological and emotional causal factors include faulty learning processes, emotional problems, dysfunctional family interactions, anxiety and hostility between family members, and stressful event are also positive factors. And physical and psychological abuse of a child and trauma, parental discord, marital discord, violence in the family, all these factors are basically commonly seen in almost all type of childhood disorders. How this disorder can be disordered? So prescription of an antidepressant drug like amipramine is generally given, and it has some effect on managing enuresis and encopresis. Due to common relapses, conditioning procedures are often used. So bell bed and method is there. So when the child urinate, the bell starts sounding. So the child get up from the sleep. So there are several psychological interventions available for to cure this problem. Let us see the one different type of disorder seen in children called oppositional defined disorders and conduct disorder. So ODD, uh, generally these disorders are categorized under disruptive, impulsive, control and conduct disorder in DSM-5. So the children who are suffering from disorders are disruptive and they have less impulse control. They share the core features of aggressive and antisocial behavior. While ODD is usually recognized by the age of 8 years, full-blown conduct disorder usually develops by middle childhood through adolescence. Presence of persistent and negativistic, defined disobedience and hostile behavior towards authority figures, generally parents, teachers, and the symptoms are frequent temper tantrums, arguing with adults, refusing instructions, always questioning rules, and non-compliance with the rule sets, doing things to annoy or upset others, being easily annoyed, speaking unkindly or angrily, or seeking revenge. These are the common symptoms seen in ODD. In conduct disorder, a child has a repetitive and persistent pattern of behaving in a way that violates other people's right or societal norms that are age appropriate. Symptoms of conduct disorders are aggression to people and animal, destruction of property, fire setting, deceitfulness or theft, and serious violation of social and legal norms. Some show cruelty towards people and animal. There is also a deliberate destruction of property through fire setting or other means. Lying, stealing, vandalism, and breaking into someone's house may also be common. Running away from their home is common. Let us see the etiology. Both genetic and environmental factors are responsible. Behavioral theory suggests that children with aggressive parents may model their parents' aggressive and hostile behavior. Inconsistent and harsh parenting with poor monitoring are consistently associated with development of conduct disorder. Sociocultural influences like poverty, urban living, unemployment, and low educational standards of parents and dysfunctional family dynamics combine and they contribute to the development of this disorder. So, what are the treatment? Family intervention, parent management program to modify responses to parents when dealing with their children, and multisystemic therapy attempts to deliver comprehensive therapy services in community, targeting the adolescents, family, peers, and schools. Let us see the attention deficit hyperactivity disorder, ADHD. So, what is attention deficit? Children display difficulties in maintaining, sustaining attention, excessive and exaggerated motor activities and impulsivity relative to their developmental level, leading to social academic activities. Children are not able to function adequately in school or with friends and family due to attention deficit. So, what happens in attention, like it could be does not seem to listen, daydreaming, careless, often loses things, easily distracted. So generally parents complain about such thing ki they are inattentive. Let us see the hyperactivity. Excessive activity manifested in two forms: motor hyperactivity, restlessness, and unnecessary body movements, fidgeting, etc., and vocal hyperactivity, excessive talking. So, in preschool children, hyperactivity can be seen in children to engage in excessive jumping and climbing on the furniture, running around the house, and in difficulty in engaging the children in sedentary activity like listening to story. In school-aged children, similar behavior may be seen, although the behavior may be lesser in intensity and frequency. So generally, parents complain and describe their hyperactivity like their children cannot sit still, keeps running and climbing, and home and school difficulty playing or engaging quietly in leisure activities, often on the go as if driven by a motor. Let us see the treatment. Prescription of medicine like methylphenidate and combined mode of therapy is commonly used. Like certain behavioral strategies include selective reinforcements in classroom and structuring of material in a way that enhances the experience of success. Family therapy is also used. Skill-based intervention has also been seen effective in reducing symptoms. Let us see the intellectual disability or mental retardation. Earlier it was called mental retardation. So, intellectual disability, also known as intellectual developmental disorder, sub-average functioning in general mental abilities such as reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experience beginning before the age of 18 years. So basically, there will be delay in adaptive functioning, and the IQ should be less than 70 on a standardized intelligence test, and the this delay in the adaptive functioning should be seen before the age of 18. So the causal factors for intellectual disability range from biological like genetic infections, toxic agents and radiation, trauma, substance use like alcohol during pregnancy, and malnutrition, etc. Psychosocial, sociocultural, or a combination of all these three: biological, psychological, and sociocultural. So they receive most of the devaluing, stigma, bullying, and shameful treatment from the lay people and medical professions. About 2% of the general population falls into category of intellectual disability. People with mild intellectual impairment can, with proper preparation, carry out most of the day-to-day activities, but those with more severe impairment, like moderate or severe or profound, may need help to eat, breathe, and dress themselves. So they need basically help from the others for doing their daily activities like uh, getting up ready, going to bathroom, taking bath, cleaning the after toilet, and dressing up, buttoning, all these things. They need help for this thing. A proper training and support, if it is given, so they can lead their life happily. But always the supervision, help, support is required. Those who are having moderate, severe, and profound intellectual disability. However, those who are having mild disability, they can uh, do certain activities without supervision also. Let us see the treatment and rehabilitation. A number of special education and rehabilitative programs have been developed. Institutionalization of people with severe intellectual disability, generally daycare type of thing, like the child goes to special school for 5 6 hours and learn certain skills there. Behavior therapy is basically based on learning theories can be used. Vocational training for those with mild intellectual disability can be given. Special education classes for those with moderate and severe intellectual disabilities. So you might be knowing the different IQ level of the this intellectual disability. So it is, if IQ is less than 20, it is profound mental retardation or intellectual disability. Uh, 20 to 34 is severe intellectual disability. 35 to 50 is 49. 35 to 49 is moderate disability, and 50 to 69 is mild intellectual disability. Let us see the another disorder which is seen in children and adult children, autism spectrum disorder. So ASD. Autism is a neurodevelopmental condition that is usually identified before a child is 30 months of age, may be suspected in early weeks of life, affects social communication, and is associated with repetitive patterns of behavior. For independent diagnosis under DSM-5 put under the autistic spectrum disorder. So first one is autistic disorder, second one is Asperger's syndrome, third one is pervasive developmental disorders and PDD, and the fourth one is childhood disintegrative disorders. So let us see what happens in this disorder. Deficits in social emotional reciprocity. The child will not emotionally react. Even if you show love, the child may not show the love. Deficits in non-verbal communicative behaviors used for social interaction. Deficits in developing, maintaining, and understanding relationship. Restricted repetitive patterns of behavior, interest, or activities. Stereotyped or repetitive motor movements, use of object or speech. So basically, the child will show repetitive activities. The child will have liking for one dress only, so it will be very difficult for the parents sometimes to change the dress of the child, and the child avoids gaze. The child not able to maintain eye contact. So it's very difficult to like emotionally attach with the child because the child does not show any emotions, no reactions toward love and affection. So insistence on sameness, inflexible adherence to routines or ritualized patterns of verbal or non-verbal behavior. Highly restricted, fixated interests that are abnormal in intensity or focus. Hyper or hypoactive reactivity to sensory input or unusual interest in sensory aspect of the environment. So, what is the treatment? So, there is no cure for autism. We all know autism is seen as a condition that leads to differences in brain wiring relative to the typical population. Treatment of autism includes management of problematic behaviors as well as training of teachers, schools, and workplaces to understand and make space for the challenges of autism. Let us see the another disorders which is basically very problematic for the students. Uh, it is called specific learning disorders, SLD. So, specific learning disorder refers to clear impairment in school performance, or if the person is not a student in daily living activities, which is not due to intellectual disability or to another developmental disorder, such as autism or attention deficit and hyperactivity. Some of the specific learning disorders are poor achievement in reading, called dyslexia, writing dysgraphia, and arithmetic dyscalculia. So basically, what happens in dyslexia, when you give the child a book to read, so what the child will do, the child may substitute the word, the child may skip one line, one sentence. So these are the problems, or difficulty in reading a particular word. Whereas in writing SLD dysgraphia, what happens? The child is know the how to write the particular letter, but while writing, he may commit mistake. For example, he may write friend. He know that FRIEND is the spelling, but while writing, he may write F opposite or FREIND like that. So, or the child may sometimes the child may skip certain words in writing also. In arithmetic dyscalculia, generally the child knows the calculation, but while the child has to perform it he may commit mistakes. For example, uh, 21 plus 42. So the child may write differently, opposite. That, but if you ask verbally, the child may give you the answer. So they are so learning disorders are not otherwise specified into a single diagnosis of specific learning disorders. So what are the treatment? Early intervention programs involve imparting of skills such as reading out loud under close supervision, phonemic awareness, etc. Interventions for increasing self confidence make learning interesting. Use of computer assisted tools like podcast, webcast lectures, tutors, untimed or oral tests, allowing another individual to write answers like that can dictate out in examinations. So, if we see the treatment of learning disability, the job of the psychologist to find out what type of disability. So accordingly, the intervention can be planned. If it is related to reading, then the reading exercises can be done. If it is related to writing, then writing exercises can be done. If it is related to calculation, then certain exercises can be done. So, so if they can get, those who are having SLD can get a certificate from the uh, medical board or clinical psychologist. So if they are having difficulty in writing, they may get scribe in the examination or extra time. Sometimes they may get calculator also. So there are certain facilities given for these children so they can continue their study. So what we had discussed today, we had discussed today about the sexual disorders, sexual dysfunctions, and sexual deviations, Unit 10. Then we had discussed about the uh, childhood disorders commonly seen in some children. We have also discussed about the some disorders and some conditions like uh, mental retardation or intellectual disabilities. So IQ test, you all knowing that in practical you might be doing intelligence tests. So the as I told you, the IQ should be less than 70, and the child should have some delay in adaptive functioning, and this delay should be less than in before the age of 18 years. So I thank you all for listening.